Ayubowan, my dear students. I welcome you all to today's session. This is a continuation of the P-wave abnormalities which we did during the previous session. I hope you can remember during the previous session we discussed normal P-wave, conditions causing tall P-wave, wide P-wave and inverted P-wave. At the end of today's session, you should be able to identify the conditions causing absent P wave, identify the conditions causing the abnormal shape P wave, and identify the conditions causing P wave that not followed by QRS complex. Okay, let's move to the first topic. Are P waves absent in the ECG? Then what are the clinical conditions should come into your mind? That absent P wave may result of atrial flutter, atrial fibrillation, hyperkalemia, mid-AV junctional rhythm, and P wave intermittently absent in the sinus arrest and sinoatrial block. Okay, let's discuss one by one. First one is atrial flutter. In atrial flutter, sinus P waves are replaced by rapid flutter waves. Normally, flutter waves are denoted by the letter of capital F. Atrial flutter is a reentrant rhythm. Most common type of atrial flutter involves a single reentrant circuit with the circus activation in the right atrium around the tricuspid annulus, with an area of the slow conduction located between the tricuspid valve annulus and coronary sinus ostium. More often, this electrical impulse travels in counterclockwise direction. In AF, electrical impulses circulate much faster than the normal around the atria. It may be 250 to 350 beats per minute, so atrial conduction much faster than it should. To control the heart rate, AV node often block some of these impulses. This causes the atria and ventricles conduct to the different speed and ventricular rate is less than the atrial rate. Atrial rate to ventricular rate may be 2 to 1, 3 to 1 or 4 to 1 and it looks regular rhythm. In these ECG strips, you can identify the flutter waves instead of the sinus P waves and it has sawtooth appearance. So if I summarized, in atrial flutter, sinus P waves are replaced by rapid flutter waves. F wave presented in sawtooth appearance. Atrial flutter waves occur at regular rhythm. Ventricular rate is also regular. If AV block is appeared, the rate may be variable. Atrial rate varies between 250 to 350 beats per minute. Atrial rate to ventricular rate ratio is 2:1, 3:1 or 4:1. Ventricular rate is slower than the atrial rate and depends on the conduction ratio. Atrial fibrillation. Here the sinus P wave replaced by fibrillatory waves. Atrial fibrillation is caused by disorganized electrical activity of the atria. Impulses are generated by the multiple sites in the atria leading to irregular heart rhythm. Only the few impulses are conducted to the ventricles. As you can see in the ECG, those fibrillatory waves are appeared like small, shallow spikes, which is called as fine waves. Fibrillatory waves are denoted by the letter of symbol F. In atrial fibrillation, fibrillatory waves replace the normal P waves. The fibrillatory waves are small. Sometimes they may be low amplitude or they may be coarse like flutter waves. Fibrillatory waves varying in morphology from beat to beat. Rhythm is irregular, variable from beat to beat. Atrial rate is very high, varying between 400 beats per minute to 600 beats per minute. Ventricular rate slower than the atrial rate, and it is usually 1/4 of the atrial rate. It may be 100 to 160 beats per minute. Next is hyperkalemia. Potassium is the vital electrolyte for regulating normal electrical activity of the heart. Normal serum potassium level is 3.5 to 5.5 milliequivalent per liter, and hyperkalemia defined as a serum potassium level is more than 5.5 milliequivalent per liter. So after this level, you can see stepwise progression of the conduction abnormality of the heart. Initially, you can see repolarization abnormality represented by peak and tall P wave in the ECG, and it is earliest sign of the hyperkalemia. Let's talk about P wave changes in the hyperkalemia. When serum potassium level greater than 6.5 milliequivalent, you start to see the P wave widening and flattening, and at the same time lengthening of the PR segment and even complete disappearance of the P wave can be noticed. In this table, you can clearly see serum potassium levels, typical ECG appearance, and the possible ECG abnormalities. In serum potassium level is between 5.5 to 6.5 milliequivalent per liter, you can see tall and peak T waves and prolonged PR intervals. When serum potassium level is between 6.5 to 8 milliequivalent per liter, P wave can be lost, QRS complex can be prolonged, ST segment can be elevated, and finally ectopic beats and even escape rhythm can be noticed. If it is more than 8 milliequivalent per liter, you can see progressive widening of the QRS complex leading to sine wave, and if not immediately treated, can develop ventricular fibrillation and can go into cardiac arrest. In this ECG, you can see tall and peak T waves. In the other words, tall and tented T waves because it's just like a tent. And also note that there is no P waves and bradyarrhythmic rhythm. So it is obvious that this is an ECG of a hyperkalemic patient, and serum potassium level may be between the 6.5 to 8 milliequivalent per liter. Another condition that P waves are not seen in ECG is mid-AV nodal rhythm. In this situation, impulses originate from the mid-AV nodal area and impulses travel to the atria and ventricles simultaneously. So both atria and ventricles activate at the same time, and atrial activation is hidden by the ventricular activation. So we can't see the P wave. In this ECG, there is no P wave before the QRS complex. You can see regular rhythm with narrow complexes. So it is the mid-nodal rhythm. P wave is buried inside the QRS complexes. Here you can see the high nodal area, mid-nodal area and low nodal area of the AV node. If impulses are generated from high nodal area, it first reaches to the atria and little delay to the ventricles. So atria activate prior to the ventricles and you can see P wave just before the QRS complex. When impulses are generated from lower nodal area, conduction first travels through the ventricles and there is a little delay to the atria. So ventricular depolarization occurs before the atria. An inverted P wave can be seen soon after the QRS complex. When the impulses originate from the mid-nodal area, it travels to the atria and ventricles simultaneously. Then both are depolarized at the same time. And atrial depolarization buried in the QRS complex, so in mid-atrial rhythm there is no visible P wave. Up to now, we have discussed the atrial flutter, atrial fibrillation, hyperkalemia and mid-nodal rhythm where the P waves are absent. Now we are going to discuss the conditions where the P waves are intermittently absent. Those are the sinus block and sinus arrest. In sinus block, sinus node generates the impulses, but occasionally some impulses may not leave the SA node to reach the atrial conducting tissues. Therefore, the atrial depolarization does not occur, resulting absent P wave with a drop beat. As you can see in this ECG strip, we expect to have a P wave here, but due to non-conducted impulse, P wave and QRS complex are absent. After a pause, SA node again resumes the sinus beat in the same way as earlier. This PP interval of the pause is multiple of the baseline PP interval. In sinus node arrest, SA node occasionally does not generate impulses, resulting temporary electrical silence in the ECG. Therefore, another electrical focus within the heart take over the impulse generation. It may within the atria or AV junction. Most of the time, the AV node takes over the impulse generation. Here in this ECG, we expect to have the P wave here, but due to the failure of the SA node to produce an impulse, there is a pause in the ECG. If the pause is long enough, another electrical focus will take over the impulse generation. Therefore, the morphology of the P wave change depending on the site of the origin. Unlike in sinus block, here the PP interval of the pause is not the multiple of the baseline of PP interval. Up to now, we discussed absent P wave and intermittently absent P wave. Let's discuss abnormally shaped P wave. Okay, are P waves abnormal in shape? If so, these things should come into your mind. Atrial ectopic, wandering atrial pacemaker, and multifocal atrial tachycardia. In atrial ectopic, the origination of the electrical activity is not from the sinus node, so the P wave would not have its normal sinus appearance. Therefore, it would have a different P wave morphology depending on where it originates. In this ECG strip, you can see the P wave's normal sinus appearance, and here there are two P waves with different morphology. Those are called ectopic P waves. Next is wandering atrial pacemaker. Wandering atrial pacemaker is an atrial arrhythmia that occurs when pacemaker of the heart shifted between the SA node and other ectopic site of the atria. That means it wanders among the different foci and produces P wave with different unusual shape. Depending on the ectopic sites, automaticity and the firing rates will be different. So, in wandering atrial pacemaker rhythm, heart rate is variable and have irregular rhythm with variable PR interval. By definition, wandering atrial pacemaker must have at least 3 different P wave morphologies and heart rate should be less than 100 beats per minute. Here you can see P wave of different morphologies and note that their heart rate is less than 100 beats per minute. Look at the rhythm strip of this ECG. What do you think about the morphology of the P wave? Did you notice that there are more than 3 different P wave morphologies? 1, 2, 3, 4. What about the heart rate? Heart rate is about 75 beats per minute. So this is an ECG of wandering atrial pacemaker. Multifocal atrial tachycardia. It is also a kind of atrial arrhythmias where we can see abnormally shaped P waves. It is somewhat similar to wandering atrial pacemaker but more serious condition than that. Multifocal atrial tachycardia also a condition that pacemaker of the heart shifted between the SA node and other ectopic site of the atria, resulting morphologically different P wave when each P wave conducted to the ventricles. Since different ectopic foci have different automaticity and different firing rate, heart rate is irregular. In multifocal atrial tachycardia, ventricular rate should be more than 100 beats per minute and PR interval also varies from beat to beat according to the ectopic foci. Multifocal atrial tachycardia also should have at least 3 different kind of P wave morphologies. Only the difference between multifocal atrial tachycardia and wandering atrial pacemaker is the heart rate. Here in this rhythm strip, you can clearly see different P waves morphologies and definitely there are more than 3 different shapes. Heart rate is nearly 300 beats per minute. Here in this ECG, you can nicely see the P waves with more than 3 different morphologies and ventricular rhythm is more than 100 beats per minute. So this ECG shows multifocal atrial tachycardia. Here the heart rate is irregular. Is there any other cardiac pathology coming to your mind when you see this ECG? What about the atrial fibrillation? In that condition also heart rate is irregular. Unlike multifocal atrial tachycardia, in the atrial fibrillation you cannot see the P waves in the ECG. Are P waves not followed by QRS complexes in the ECG? If so, the pathology should be in the AV node. So the following are called AV blocks or hard blocks where the P wave is not followed by QRS complexes. Morbitz type 1 second degree AV block, Morbitz type 2 second degree AV block, high-grade second degree AV block, and third degree AV block. Morbitz type 1 second degree AV block, also known as Wenckebach. Here the PR interval progressively prolongs with each beat and one P wave is not conducted to the ventricles, leading to dropped QRS complex in the ECG. Here in this ECG strip, you can see PR interval is gradually increased and this P wave is not followed by QRS complex. From the next beat, AV conduction resumes as earlier and again the same pattern repeated. Morbitz type 2 second degree AV block. Here the PR interval remains constant and intermittently there will be a drop QRS complex due to non-conducted P wave. This may happen in frequent intervals. In this ECG strip, you can see that the PR intervals constant and this each P wave is followed by QRS complex. But this fourth wave is not followed by QRS complex. The next P wave is again followed by QRS complex and this pattern repeats. Here you can see 3 conducted P waves to 1 non-conducted P wave. So the conducted to non-conducted ratio is 3 to 1. This ratio can be either 2 to 1 or 4 to 1. Second degree high-grade AV block. This is characterized by fixed ratio between non-conducted P waves to conducted P waves. The ratio of P waves to QRS complex may be 2 to 1, 3 to 1 or 4 to 1. This can be a result of either Morbitz type 1 or Morbitz type 2 conduction. Significantly low ventricular rate can be seen in this situation. Here in this first ECG strip, you can see every second P wave is followed by QRS complex, and the second ECG strip, every third P wave is followed by QRS complex. So here, after first and second P waves, there are no QRS complexes. Here, the first P wave, second P wave, and third P wave, after that QRS complex. Again, first P wave, second P wave, third P wave, and again QRS complex. Therefore, the P to QRS ratio is 3 to 1. And above strip, you can see 2 to 1 block. In 2 to 1 block, ventricular rate is half of the atrial rate. And 3 to 1 block, ventricular rate is 1/3 of the atrial rate. So what will be the 4 to 1 block? Obviously, it is 1/4 of the atrial rate. In third degree heart block or complete heart block, there is no relationship between the atrial contraction and ventricular contraction. Here none of the atrial impulses reach the ventricles due to complete absence of AV conduction. Ventricular rhythm is maintained by junctional or ventricular escape rhythm. If it is junctional rhythm, QRS complex is narrow. If it is ventricular escape rhythm, QRS complexes are broad. Complete heart block occurs when there is no action potential conduct through the AV node. P waves or atrial depolarization being completely unrelated to the QRS complexes or ventricular depolarization. The P wave occurs at one rate and the QRS complexes at another. This is termed AV dissociation. So in this ECG rhythm strip, red arrows are showing P waves and blue arrows are showing QRS complexes. Here you can see atrial depolarization are completely unrelated to the ventricular depolarization. So the P wave occurs at one rate and QRS complexes at another rate. What can you see in this ECG? There are P waves not followed by QRS complexes. Here you can see separate atrial rhythm and separate ventricular rhythm. Atrial rhythm is regular. It is nearly 120 beats per minute. And ventricular rate also regular. The rate is nearly 27 beats per minute. So this is a third degree heart block. With this, I have completed all the P wave abnormalities you are required to know. In next lecture, I will discuss abnormalities of PR interval. Have a nice time. Take care. Thank you.